largest structure within the eye, but mostly invisible, the vitreous has received only little attention throughout the past. Consisting of merely water and macromolecules, its outer shell is called the posterior vitreous cortex. During the aging process, the vitreous loses its gel-like structure, resulting in liquefaction and in the collapse of the vitreous. The separation of the posterior vitreous cortex from the membrana limiting interna is what we call a posterior vitreous detachment, or as we say, a PVD. Recent studies have shown that the interaction between the vitreous and the retina seem to play a very crucial role for the pathogenesis of many posterior pole disorders. We at University of Marburg ask ourselves the question, which method is the most reliable one to be clinically detect a posterior vitreous cortex properly? In our prospective study on 30 eyes of 30 patients, we examined 1 day prior to scheduled vitrectomy due to macular pucker or macular hole formation whether the posterior vitreous cortex was attached or detached. Three independent investigators examined the posterior vitreous cortex. One expert was only allowed to use a B-scan ultrasonography. One expert was only allowed to use an OCT, Optovue or Stratus. And the third one was only allowed to use a slit-lamp to assess whether the posterior vitreous cortex was attached or detached. 1 day later, through triamcinolone-acetonide-assisted vitrectomy, one surgeon said whether the posterior vitreous cortex was attached or detached. And these were our findings. Vitrectomy showed in 60% of all cases a firmly attached vitreous, and in 40% of all cases a PVD. So, which expert was right? The expert using the B-scan ultrasonography was right in 25 eyes and wrong in 5 eyes. The expert using only the slit lamp was right in 23 eyes and wrong in 7 eyes. Surprisingly, the expert using the OCT was only right in 1 eye out of 30 eyes, wrong in 7 eyes, and could not make any possible assignment at all in the total of 22 eyes. The best one was the expert using the B-scan ultrasonography with 83% correct perioperative evaluation of the posterior vitreous cortex. The second best one was the one using the slit lamp with 76% correct evaluation. The expert using the OCT, whether it was Stratus or Optovue, was only correct in 12% of all cases. The expert using the OCT saw in 70% of all cases no fine preretinal line above the macula, so he could not make any possible assignment at all. In the remaining 30% of all cases, he did make an assignment which was only correct in 1 case, and that's a total of 12%. We wanted to show you a representative case of our small study. You see in the slit lamp examination a macular hole formation. The expert using the slit lamp said that the vitreous is attached. Our second expert used the ultrasound and also said the vitreous is attached. In the OCT, you see a fine preretinal structure above the macula, indicating that it might be a PVD. 1 day later, our surgeon made a vitrectomy with triamcinolone and said that the vitreous was indeed attached. So, two-dimensional OCT often displays a fine preretinal structure above the macula, which we believe to be a PVD. But what is this fine preretinal line really? Is it really a PVD, or is it possible that the vitreous is indeed attached and that we are looking at a fine rear panel of a bursa primacularis maybe, and that the vitreous is attached and not detached? Our study has shown that there is no such reliable technique whatsoever to assess the posterior vitreous cortex properly. The best methods still remain B-scan ultrasonography and the slit lamp examination, but they remain dependent of the skills of the examiner. The method with the lowest reliability index was the OCT with only 12% correct evaluations. So the OCT, two-dimensional, seemed to be very limited to assess the posterior vitreous cortex properly. In the future, we hope that three-dimensional OCT might be able to assess the posterior vitreous cortex in full. Thank you very much.
Thank you. This is now open for questions.
Very interesting that the modern OCT failed to live up to its standards with only 12% of success. And you mentioned in your end that the three-dimensional OCT could become more useful. Having used the RT view, it also has a three-dimensional aspects that you can make sections and go. Did you use that?
No, we didn't, no.
Okay.
Actually, the problem lies with the translation of OCT, because many machines today, how to convert the picture in a digital form, because you get in one OCT that you get that it is a, if you are doing for glaucoma, they say that it is in a green area, and one OCT tells that it is in a red area. And if the eye is myopic, high myopic, the readings are all different. So in OCT, they pick internal limiting membrane as the first test. I'm surprised that there is a gap between the internal limiting membrane and this. How do you explain this? So, any comments?
I mean,
Just the surgeon one time prior to vitrectomy, and then the vitrectomy proved whether it was attached or detached. Because most of the eyes had then some fluid within, like.
So how the surgeon interpreted that?
The surgeon did not interpret this at all.
I understand that, but now
No.
So any specialist?
Yeah, he said that this might be a bursa primacularis, that the vitreous is attached or not detached.
I understand that, but what is that line?
We don't know.
one comment, kind of. Of course, the image and how it is digitally represented is always a question. But also, how did you kind of compare the skills of the examiners, the experience of the examiners? I mean, how do you know that they're all gold medalists and World Cup champions?
They were our professors. We assumed that they had some experience.
The criteria on ultrasound, the state that it is detached, is it based on the motion of the posterior vitreous? And the OCT, this is a static photograph.
Yep.
So there's no way to reduce motion when measuring the OCT.
That's right.
And on a biomicroscope, it was done by 90D or with the contact lens.
90.
So again, then by doing 90, it is controversial when you do the 90D
Thank you.
or with the contact lens. So there are some gaps somewhere.
Okay. Thank you. Next, I'd like to introduce